to see everyone virtually. Um, I'm Dr. Mark Solomon. I'm out of Orlando, Florida, and Advent Health now. It's a tremendous honor to be doing this type event virtually. You know, I think we've discussed it in a previous webinars. You know, this has been something that we've been doing for the past 10 years now, and then obviously with COVID messed a lot of things up. But I think the silver lining is that we're able to kind of do this type deal. Far-reaching, without too much disruption to your personal life, and without too much disruption to your professional life as well, having to travel. So it's nice to meet everyone virtually, and I hope, as I think we all do, to get back in a physical lab and physical classroom to meet everyone face to face again. As many of you know, this is a second in a larger series with the APDCRS. And what we're trying to do basically is we're trying to augment, not replace, but augment the learnings that are happening at your local campuses when it comes to robotic colon and rectal surgery. So the first discussion, as you guys are well aware, was a discussion by Dr. Ima Approach, which was basically the setup for a robotic case in general, the port configuration, most importantly, the port placement philosophy. And in this discussion, what I'm going to attempt to do is talk to you guys about the IMA and IMV high ligation. But actually, I'm going to back out just a little bit and talk a little bit more even about the medial to lateral dissection in general. And the reason I think this is important is because this is effectively the first part of a low anterior resection. And even though Dr. Basaris in the first lecture spoke to you guys about right colectomy and intraportal anastomosis, now we're shifting to the left side. And I really want to talk about how to set the whole case up. And what I've done is on purpose selected videos that you guys may have seen. If you're aware, I have a YouTube channel. If not, it's youtube.com/Mark Solomon. Feel free, please, to go to it. All the videos that I'm going to discuss today are on there. And the reason I did that is because I know the limitations of Zoom for portraying video. And so for that reason, I want to make sure that you guys had access to the basically higher quality videos, and that's not going to be all jaggedy and jerky as we're doing right now. I'm going to sprinkle in some additional videos in this talk, but effectively you'll have a pretty decent access to stuff post-discussion. All that being said, what we're going to do also is there's a chat box that's open. Do not be shy. We want to hear the questions. We want to keep this as dynamic and as interactive as possible as we're going through it. All right, so without further ado, let's just get started here. So again, you guys are probably aware, and if you're not, please do go to my YouTube channel where I break down both the left colectomy or low anterior resection and right colectomy into digestible chunks. And in this specific operation, I've broken down a low anterior section, and this is just the way that I think. I break it down into 21 steps. We start by positioning the patient. We then access and insufflate the abdomen. We place our ports. We explore the abdomen. We position the bowel, and then we dock the robot. And I'll pause here and just say, take your time in docking the robot. It gets frustrating if you don't first laparoscopically position the patient and the bowel prior to docking the robot for rights or lefts. So just make sure things are set up prior to you docking. And what we're going to do today is we're going to discuss steps 6, 7, 8, 9, and 10, which starts with the medial to lateral dissection, starts to identifying the hypogastric nerves and preserving them, getting the ureter out and preserving it, skeletonizing the IMV and doing the high ligation, and also skeletonizing and dividing the IMV and dividing it as well. And then that's what the discussion for today will be. And then in an upcoming lecture, I believe it's Dr. Cleary is going to speak about splenic flexure takedown, but that's for a different day. Okay, so here's the outline for the day. We're going to talk about the vascular supply, which is incredibly important. We're going to talk about a bunch of anatomical relationships, which is also incredibly important. And then we're going to talk about a few different approaches to mobilization for the medial lateral or lateral to medial, but in order to get the IMA and IMV dissected out. And the reason I break it down like this, and it's going to sound very familiar to a video that I have on YouTube, is because I have screwed this dissection up so many times. Please learn from the mistakes that I've made. And I'm going to speak to you not as a professorial type perspective. I'm speaking to you from experience because I did not learn this in residency or fellowship. I legit had to make this up as I was going along. So please take from this what you need to, and just understand this is a lot of the stuff that I'm speaking to you today is born out of problems and complications or near complications in the OR. All right, let's start with the vascular supply, which really it sets us up for the whole discussion. We know this. We know these diagrams. They're pretty straightforward. But again, if you can just imagine for a second that starting with the arterial anatomy, your aorta is as it normally is, straight down the middle of the abdomen, and then you got your duodenum just going right in front of the duodenum with your SMA on top of it, and just below it is your IMA. Taking off from your IMA, this beautiful cartoon-ish diagram here is going to show a short trunk of the IMA with an ascending branch of the left colic artery, which is depicted here. And then basically after you bifurcate off of the left colic artery, you have all your sigmoidal vessels. And in this diagram, it shows basically like maybe like a half centimeter, maybe a centimeter chunk of an IMA, very short. So when we talk about high ligation of the IMA, we're talking about division way up there next to the root of the IMA, right at the takeoff or right just distal to the takeoff from the aorta. So as soon as it bifurcates to the left colic in the superior hemorrhoidal, then it no longer is the IMA. A lot of us, hey Dr. Clear, good to see you, sir. A lot of us will think that the IMA is a little bit lower down. I'll show some operative videos in a second. But you got to be careful, because once it bifurcates to the left colic, it's no longer the IMA, it's actually something else. And there are reasons that we do high ligation of the IMA, which we'll discuss in just a minute. Now, the more important diagram is on the right here, this angiographic image. So on the right here, as you notice, they got the catheter tip within the root of the aorta, and the radiologist has shot some contrast, and you can see that there is your inferior mesenteric artery, and then right as the contrast basically bifurcates, it splits into this very acutely oriented left colic artery that's heading effectively up towards the splenic flexure. And then at that bifurcation is right when the name changes to superior hemorrhoidal. It's at that point that that name changes. Now again, what you want to make sure is when you're doing these operations, you do a high ligation in the true IMA, not, for example, the left colic, and not, for example, the superior hemorrhoidal. In a larger patient, someone that has more central adiposity, it can be very scary to do this dissection, no doubt. And again, you don't need to always do a high ligation of the IMA, but just keep in mind that if you're not seeing this bifurcation, then you probably aren't quite low enough. Okay, so that's arterial anatomy. Keep that in mind. I want you to burn this little diagram to your mind here, because it's going to make a whole lot of difference when we start talking about how to ligate that artery. All right, now let's talk about the venous anatomy. Obviously very different. We know this. And even though the IMA and IMV run parallel to each other, they have very different insertion points. So the IMV here terminates onto the splenic vein. Completely different termination point, really. But in the OR, they run right next to each other. So I remember in residency or even in fellowship, we talk about, oh, we took the IMA and IMV together. Well, that can't be true, obviously, because the IMA, IMA and IMV don't run parallel. The IMA runs, it really terminates and bifurcates to the superior hemorrhoidal and the left colic. So by the time you actually are seeing the IMV, what it's running parallel to is actually more like either the superior hemorrhoidal or the left colic. So it's very difficult to say that you took those two vessels together. So just be careful when we're talking about high ligation of the two vessels. IMA, we're talking about basically right off the chunk, the takeoff of the aorta, and IMV, we're talking about way up here at the lower border of the pancreas, just before it dips into the splenic vein. So we're talking about a much, much, much different insertion point here. Again, you guys are going to see this video when we talk about the anatomic relationships. I did this little video on my iPad. I'll kind of run us through it real fast. And this video is going to show pancreas, IMA, IMV, and ureter. You're going to see the orientation here, and I'll pause it. You can see here, aorta. Here's the IMA. The IMA then shoots off the left colic, which is heading up here now. And then this now, right at this bifurcation, the name changes to superior hemorrhoidal. And then look, very intimately involved. this guy coming up here, that is your IMV. So I'll let the video play and you can see it in 3D what the relationship looks like. And again, as I was saying a minute ago, if you think that you are ligating the IMA and the IMV in parallel with each other, you're probably not right. There's only one point that in this diagram, at least, they run right next to each other. So if you're ligating IMA and IMV together, really what you're doing is you're ligating the superior humeroidal and the IMV together a lot of times. Okay, I'll let it play. And you can see what the anatomical relationships look like. You can see where the left ureter is. Left ureter runs deep to all this. I'll show some kind of graphical representations of what this anatomy looks like. And I'm just kind of panning the image around here. Scrolling down, that's your superior humeroidal, bifurcating. And we're going to come up, watch the vein. Vein, 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 coming up, coming up, coming up. Much larger caliber, dropping below the lower border of the pancreas, below the duodenojejunal junction, and right there inserting to the splenic vein. I want you to burn this diagram or this 3D model or whatever you want to call it into your memory, because in the OR, when nothing looks like anything or everything looks like nothing, depending how you look at it, this is sometimes the only thing that you could try to reference, because these operations can be very challenging. So again, schematically, this is what you're looking for. You're looking for the IMA. You're looking to begin your dissection just behind the IMA, to come below the IMA, behind it, behind the IMV, anterior to the ureter, anterior to the gonadal vessels, but yet still behind the descending mesocolon and sigmoid mesocolon, sweeping it up, Tolt's fascia, gonadal vessels, and all this, the critical structures down, and all the other stuff that's coming with you goes up. So this is what we're trying to reproduce. And so what we'll do for the rest of this conversation is talk about how to actually get this done from a technical standpoint. And then in my mind, I do this in 3 different ways. Now, I know some of my partners here in Orlando, they love the sub-IMV approach, and we'll cover that in a second. And I like the infra-IMA approach, and we'll talk about that in a minute. But there's also a supra-IMA approach. There's tons of different ways to do this, and there's no one single correct way. And then also, a lateral medial is also totally safe to do. But I'm just going to talk about these 3 for the purposes of this discussion. And again, we want you to ask questions and comments and criticisms along the way as well. Okay, so let's talk about the infra-IMA. What I want to do first here is show you the robotic setup. And because this is a challenging thing when we get to the OR, is okay, you saw the videos of how to actually do it, but how do you make the exposure look right? So this is how I do it here. And by the way, this is after all the lateral attachments have been taken. So sometimes you'll get in the OR and you got diverticulitis, you got whatever, and then the sigmoid colon is plastered to the left abdominal wall. I promise you, there are very few instances in which adhesions help you. Yes, I know that you may have an attending in residency talk to you about that. Yes, I know one of your chief residents at one time said, oh no, leave the adhesions in place. They're helping with retraction. Look, you have a robot with 4 arms on it. You have an assist that can assist you. Take down the adhesion such that the anatomy that you're dissecting and everything that you're doing is reproducible every single time. And that way you're not relying on the adhesions being in the exact perfect spot each time. I can count on maybe one finger how often an adhesion has actually helped me with retraction in a robotic operation. Laparoscopy I get because you need that help sometimes. But once you, doc, get all these adhesions taken down, make sure you restore the anatomy to something that looks more normal and then get started. So that's where we're going to pick up this video. Tip up is holding the tip up is holding the mesocolon up like that. I'm going to identify basically where the junction of the mesocolon and the retroperitoneum exists. And I'm going to pause the video right here. And you're going to see here, and again, I do this in a video on my YouTube channel, so you'll see it, that basically what I'm highlighting here is a bright yellow fat that I'm mousing over right now. That is where the mesorectum is. And if you can imagine that the peritoneum is a thin veil or a thin sheet of kind of opaque-ish covering, lining, like saran wrap, call it, you're peering through that to see, can you find the mesorectum and can you see the retroperitoneum? So if you do this right, and you've tented things up and the adhesions are out such that you can pull the rectosigmoid out of the pelvis, this should be your view. And when you do that, you're going to see kind of a bright yellow fat here intersecting with a more opaque, pinkish, salmony, kind of whitish look here. And that's the retroperitoneum. What you're trying to do with the medial to lateral is predict where that intersection occurs. So look here. I'll pause it right when I lift up. Right there. Bright yellow, not so bright. That's my incision right there. Each time I'm going to put it right there at that intersection point. And sometimes I get it wrong. A lot of times I get it wrong. Sometimes I get it right. But once you make your incision right there, all that pneumo dissection starts helping out. Your hypogastric nerves are effectively immediately visible. Some little small bridging vessels are going to be visible. Do some sharp dissection, and within a few swipes of the scissors in this case, I'll see the ureter. Now notice what my left hand's going to do. Poke, spread, lift. Always a poke, spread, lift. Never want to grab. It's very easy to grab in these cases. There's a left ureter right there. I'll play that one more time. I want you guys to see that, the poke, spread, lift maneuver. Look at my left hand. Left hand's going to, in that incision point, I'm going to go in. I'm going to poke, spread, and lift. And look at that right there. Look at my left hand. What it's doing is it never wants to grab. The second you grab something, just assume it's going to rip it. So if you poke, spread, and then lift it towards the head of the patient, you're actually pulling the mesorectum up. You're pulling the specimen essentially up, leaving the retroperitoneal structures down, and you'll very quickly be able to identify that left ureter. Poke, spread, lift, like I'm doing with my left hand. Identify that left ureter right there. So keep that in mind as you're doing these cases. The second you grab something with your hand, it's going to rip. All right, now here is my ballerina patient. She is amazing. So she had a kind of a nasty little sigmoid cancer, actually proximal sigmoid, distal sigmoid rather. And in this case, I'm showing this video purely to demonstrate what the anatomy looks like. We never get patients like this ever. So I'm going to show you a few more videos that show different types of anatomy and larger patients, and also videos that aren't even mine to help show this anatomy. So this is what ideal looks like, and you will almost never see this. But keep in mind that when you're in the OR on your own, when you first start practice, when you're lost, waiting around in fat, this is what your mind's eye should try to remember. So here on the left of the screen, this is her transverse colon. Top left of the screen is the splenic flexure. At the top of the screen is her descending colon. Looking here now, this is my fenestrated bipolar in my left hand. I have a hook cautery in my right hand. This big black vessel right there, big purple vessel, that's the IMV. You won't quite see in this video. The IMA is just immediately below it. Just below that, where my mouse is, that is the aorta. And then here to the left of screen is my duodenojejunal junction. And you can see pretty clearly that she is skinny, 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 and has its own set of issues, but it's going to be a nice dissection. So I'll play the video to show the choreography of the beginning of the dissection, followed by the beginning of the high ligation of the IMA. This is an infra-IMA approach. There's the areolar tissue plane. I'm pushing down those structures. Poke, spread, lift for my left hand. Identify the left ureter. Get into the presacral space. It's an older video because I'm using hook cautery and not scissors. But you can see, obviously, it can be done with either instrument, no problem. Left hand, poke, spread, lift, pulling towards the head. Again, this is my infra-IMA approach. You can see, no matter the BMI of the patient, they're going to have this plane here. It's just a little scary to find a larger patient. I'm going to let this video play, and then I'm going to stop it and rewind and show some tips and tricks using the third arm and exactly what I'm doing. But right here, you can see the insertion point of the IMA onto the aorta. I'm getting around this guy, and I am basically skinning it down to the takeoff of the aorta, doing our high ligation. You can see where the vessel bifurcates. To the right is the superior aorta. To the left, heading upstream here, is where the left colic is. And I'm taking it just distal to the takeoff from the aorta. And the reason I'm doing that is I always leave about 1 centimeter to 2 centimeter cuff so that not when, but if, sorry, not if, but when I screw something up and I lose control over the vessel, I can grab it, stitch it, put an endo loop on it or whatever. Okay, so that was IMA division. And what I'm doing now is I'm continuing that medial to lateral dissection. But notice where my third arm is now. Third arm is kind of tenting up the divided IMA pedicle. I'm going to come up here. We're going to skinny around. Again, the skinniest patient on the planet, just showing the anatomy, getting around the IMV. This is, again, just to demonstrate the anatomy. Here's the duodenal-jejunal junction and dividing right at the lower border of it or the lower border of the pancreas. And there's the pancreas there to the left of screen, which is insane how skinny this patient is. Keep noticing what my third arm is doing. I just keep advancing it, and it's holding basically a triangular configuration. There's pancreas right there. Again, I will rewind and show these technical tips as we're going back through all this. Now the next step in this part of the operation, sweep the pancreas down. And once you sweep the pancreas down, you're able to enter into the lesser sac from a medial approach. And that's one of the nice benefits of this dissection, is that you can truly do a very elegant, very quick, and a bloodless dissection in a medial to lateral manner, taking the splenic flexure down without too much difficulty, even in the larger patients. Pushing the pancreas down. And as I'm pushing the pancreas down, I'm always keeping my mind's eye on the lesser sac. So I'm trying not to head directly towards the spleen. I'm trying to head basically to the transverse colon, transverse mesocolon, so I can try to find, again, a lesser sac. So that's what the next move here. I know this discussion isn't about splenic flexure mobilization, but this dissection comes so hand in glove with the splenic flexure mobilization. I just want to play it out, and since the video is already here. Poke, spread, lift, left hand. Pancreas goes down, now into lesser sac. And then what we do here, again, watch where my third arm is. Third arm is always at basically the 12 o'clock position, creating a triangular orientation of all the tissue. Okay, I'm going to stop this video. Rather, I'm going to rewind this video, and then I'm going to show all those technical tips that I was mentioning. Starting right. I'll let this play. So starting at the IMA division, notice what's going to happen with my third arm. My third arm, once I find it, what I want to dissect, right there is a perfect depiction of what's happening. My third arm is at the 12 o'clock position. Left arm is basically at the 7 o'clock position. Right arm is basically at the 5 o'clock position. This triangular configuration is essentially what you're trying to replicate throughout the entirety of the case. You're trying to create basically a tent, like a teepee, if you will, a triangular teepee. And so here I'm trying to get around this vessel. Now, ideally, I want the IMA actually at a right angle. I don't want it down. Look, it's like, I don't know, it's 60 degrees, maybe 45, kind of coming off the aorta. Ideally, I want it to be 90 degrees shooting straight up in the air. And I want my third arm to help do that, to lift it up into 90 degrees so I can make sure that I'm able to get around it, not injure anything, and I can see all sorts of stuff. This specific patient had an obstructing cancer that tethered her rectus sigmoid junction to the pelvis. And so there was a difficulty in me pulling things up. So I wanted to kind of do the vascular ligation first in this specific case. So that's why the angle is like this. But in the average patient, you want to get that so that the IMA is sticking north-south in this case. So that's the first point there. Holding at a 90-degree angle in this, call it 12 o'clock, 5 o'clock, 7 o'clock orientation. Getting around this vessel, and then you can staple it, you can vessel seal it, you can clip it, whatever you want to do. Do it. I mean, the same tenets are going to be held for laparoscopy or even open surgery. So there's the vessel ligation here. A little technical tip here on the vessel sealer. This is I trust nothing, so I seal this thing about 4 times and then open it and check to make sure it has completely been sealed, and then I cut it, or then I seal it again, then cut it. If there's any questions, especially in your first year of practice, do not be a hero. Seal that thing extra, put a clip on it, do something. Just make sure that you've done it and you can sleep well at night. Okay, next tip. The second I have divided the IMA pedicle, look what my third arm does. Third arm is going to continue with that northern traction of the divided mesocolon. A lot of times I'll actually grab the actual divided pedicle, lift it again north. So always that northerly motion of the arm pulling directly north is important. Again, look at my left hand too. It's just bluntly lifting. I'll rewind it so you see it one more time. Left hand, what's it doing? Not grabbing a thing. It's just lifting. Poke, spread, lift. It's always bluntly lifting things. Third arm again is pulling up for us. Let me fast forward just a smidge here. I'm going to skeletonize this vessel. We'll divide the vessel here. And then watch what happens. After I've done this, I'm going to hand the divided IMV pedicle to what? My third arm. It's going to grab it, lift it directly north. And then I'm going to continue heading in this northerly direction towards the head. And then I can get down to the lesser sac. And just because she's skinny, we can see it right there. That's her splenic vein right there. You see how skinny she is. So it's great. It's not, you're probably never going to see this view again, but bear in mind there is still a pancreas there and there is still a splenic vein there. So when you're doing these medial to lateral dissections, just make sure that when you do it, your plane is not below the splenic vein. You must make a very conscious effort to stop dissecting in the natural plane that you just started. You got to stop, step above this, push the pancreas down, and that's the point at which you enter into the lesser sac. Okay, I beat this video to death. Let's go to the next video here. Next video here is again going to talk about a slightly larger patient and what that dissection looks like, and where to begin the medial to lateral. I'm jiggling the mesorectum here. Again, I'm looking at that bright yellowish to salmon pinkish yellowish, salmon-ish, whitish look in the retroperitoneum, and that's the point at which I'm going to make my medial to lateral. Going to start right there. Nice plume of pneumodissection. Once that pneumodissection starts, I'm going to continue working in this avascular plane. I think I'm actually off plane there. And I'm going to work to get the IMA dissected. Poke, spread, lift with my left hand. Look at that. Brushing down. There you go. Lifting up with my left hand. Brushing down with my right hand. Looking, looking, looking. And if you can imagine what we're trying to do is I'm trying to essentially, the IMA sits flat on the aorta. By doing this, what I'm doing is I'm dissecting and I'm basically opening the book, trying to create it so it's no longer 180 degrees or parallel to the aorta. I want it to be 90 degrees like an open book. And that's what I'm doing here. Looking for left ureter, looking for iliac, looking for all these horrible structures that I never want to see actually in real life. We want to see them just for that one period of time and then avoid injuring them. And then we're going to keep working our way around to get all this, get the IMA pedicle divided and the high ligation done. So that's a slightly larger patient. The surgical tenets are exactly the same, of course, and the strategy also exactly the same. Left hand, poke, spread, lift, lifting up towards the head, brushing all this areolar tissue down. And you can see this is a larger patient. I'm having a little more difficulty finding the left ureter, but it's up here. I can see it coming into view. And once I find it, then I know exactly I need to stay on top and everything else goes down. You see I'm using the 30 up view rather. Making sure I identify my critical structures. And once all that's done, there's ureter there, I think. Eventually she'll move. She moved. And now we're just going to keep heading upstream around the IMA pedicle. So I'm just going to keep this dissection heading in a northerly direction, looking for right there. You see where the superior hemorrhoidal is. I'm going to keep heading north until this guy inserts and takes off from the aorta. And I'll fast forward just the video just a little bit so we can see that. All this areolar tissue is going down. Let me fast forward a little more. Third arm's coming in to play. Fighting Assist isn't really helping, but it's okay. Now we're going to continue skinning down around the IMA pedicle. This is real surgery, so it's not edited. This video is not edited at all. This is about a 20-minute clip for the whole process. So just to give you an idea of, sometimes they're super fast, sometimes they take a lot more time. So that's what that approach looks like there. So I'll fast forward a little more. And then here, actually this video, I'm gonna save this part of the video for a different slide, talking about the sub-IMV approach. All right, next video here. This is another robotic case. It's actually not mine, but does a good job of demonstrating some of the technical tips of getting this case done. You see this person's assist is holding the mesorectum up out of the pelvis, and then there's some internal collisions happening here, which are not the most elegant. No criticism, does a good job with it. Just a comment. Again, starting with that infra-IMA approach. Get into the presacral space first, finding that areolar tissue plane, heading now north, and essentially scoring the peritoneum. And this is what Dr. Bastaros will do. Dr. Bastaros talks about scoring, a little too deep there. Dr. Bastaros talks about scoring the peritoneum from the level of, man, did he get the ureter there? Or is it the iliac? What is that? Oh, geez. Okay. Dr. Bastaros always talks about getting the, scoring the peritoneum from basically the ligament of trites all the way down to the presacral space, and then he'll kind of do the dissection from that. And so there's nothing wrong with that. I think it's a great idea, because you hear all that approach is happening. The assist is helping. I don't see where this surgeon's third arm is, which can be a marker of someone that's pretty early on their learning curve, especially where you see they passed point there. Heading up here, north. Pulling up all this. Fast forward just a little bit. There's a ureter finally. And as we continue heading in this direction, let's see how this surgeon does with the IMA actual skeletonization. So you can see it thumping kind of in the corner here, and you can kind of imagine just dipping down right there to where the aorta is. So this is another approach here. I was starting to demonstrate that one video, but I'll save the discussion about the sub-IMV approach more formally into a different slide. But this is a manner in which to get that IMA high ligation skeletonized and ready to go. Is if you can't see it from below, get on top, create a window, and work your way around it. Fast forward here a little bit. Get to a better spot. All right, so let's talk about this actually. I think this is a good video to show what not to do. Okay, so notice here, do you guys see the ureter? Negative. Do you see a window above the IMA pedicle? I don't. And full disclosure on this video, I'm actually moderating a panel in a few days on ASCRS on this exact same topic, which is where I borrowed this video from. I want to show some other videos. And this one is going to get I'm going to make a comment on this, because I think this is somewhat, this has some room for improvement, because I don't see where the other end, I don't see what's behind here. There could be, it could be duodenum there. There could be left ureter. There could be renal. I mean, there's a lot of stuff that could be here. And I think that there's not enough skeletonization of this vessel to show. There's not a skeletonization of this vessel to safely do that maneuver there. So I'm glad this video was actually shown, because it shows you how not to do this. You can see IMV is a little bit higher up there, but please keep that between us. All right. So there's IMA ligation. That was the infra-IMA approach. Now let's talk about the super-IMA approach. I mentioned a minute ago that when you do these cases, sometimes going below the IMA, you just can't find where the IMA and how it's inserting to the aorta just because it's too fat or whatever it is. So here's a manner in which once you've done that infra-IMA approach where you go above the IMA to help you out. You can go directly above. So just a little case context. Let me pause it. To the right of the screen down here, way to the right of the screen. That's where all that infra-IMA mobilization has been done. And just up here is that bare area right around the top of the IMA pedicle. I'll play the video, and this is where I get stuck. What I always do in these cases, I always start infra-IMA, and then if I can't find the left ureter, then I go supra-IMA. And if I can't find it there, then I go sub-IMV. If I can't find it there, then I go lateral to medial. So I'm always going that decision tree right there. Infra-IMA, look for the left ureter, can't find it. Then supra-IMA, look for the ureter, can't find it. Then I go lateral to medial if I can't find it. And I just keep going back and forth into all those different dissection planes. Fast forward here. See here in just a second. Hopefully, left ureter comes into view in just a second here. Coming into view right. You can clearly see I'm off plane there. Let's go gonadal. And now we're going above it there. So now we're just going to work to skinny these two downs, thin all this IMA pedicle out so I don't do what we just seen in that previous video. Now I'm talking about the sub-IMV approach, and this is what a fantastic approach to these operations is starting a vein first. Now this I will do almost every single time if I know I'm taking the flexure down in that case. And you'll see here, third arm is at the 12 o'clock position, left arm's at the 7 o'clock, right arm's at the 5 o'clock position. You see duodenum, IMV is right here, dropping down to the duodenal junction just below the pancreas. And I'm going to lift up the IMV, poke, spread, lift, dissect all this out to do this vein first approach. Poke, spread, lift. You can tell this is a much earlier video of mine. I can tell because I'm much less aggressive in this case. You can tell. Like when you get a few hundred cases in, you know how much you can push things, and you get your kind of your mind's eye as to tissue tension and the speed in which and the velocity at which you can actually move the instruments. And I can tell that this is a little, slightly more novice video of mine. And I'm just going to kind of work my way around this vein. But same thing that we've been taught to do, or rather, I'm sure many of you have been taught, I wasn't, about the vein first approach, which is a beautiful, beautiful way to get this done. So that's the manner in which you do this. I'll let the video play out, releasing some of these adhesions. I'm really taking my time to skinny this down. Good gracious. Fast forward here. We'll get things moving. Sweep this down. You get the idea. We're going to just keep skinning this vein down. Stay in the kind of the retroperitoneal plane. You can also see that if I mess this up, this is actually, I believe that's one of the renal vessels down here. A little bit lower down, so you can see how easy it is to get off plane and hurt something. I'll fast forward here just till we get this dissected out. While this video is playing, Dr. On asked about what angles of Trendelenburg and left side up do you position the patient during this. So pretty much all my low anterior resections, I start with the patient in 30 degrees of Trendelenburg and a left side up, right side down tilt of 10 degrees, so 30 and 10 in all these cases. It sounds steep, but once you what I do is I actually position the patients first before the operation even begins, test them in that 30 degrees Trendelenburg with no drapes on, so everyone can see that they're doing okay and they're safe, and then we actually dock the robot and get the case started. All right, those are my videos. Those are the high ligation of the IMV, high ligation of the IMA, the different approaches, super IMA, sub IMA, sub IMV. So with about 17 minutes, what questions does everyone have in the audience? And I have about 90 terabytes of videos to pull up. So if you guys want to see anything else, whether it's on this or a different type operation, please don't be shy. Use the Q&A section down below. And I'm going to stop my share for a moment. Yeah, okay, here we go. Good question. Hanju Lee, great question about, can you discuss some rescue strategies when IMA ligation site starts bleeding? Yeah, that is like a dreaded part of the operation in which bleeding starts to occur. And so what I end up doing, again, I always set the case up to just assume that's going to happen, right? I want to make sure that that not if, but when I lose control of the vessel, I'm able to quickly grab it. So that's why I always keep a cuff, about a 1 to 2 centimeter cuff, so I can grab it and ligate it or stitch it or do something to grab control over it. Now, I have seen instances in which the IMA gets just straight up avulsed off the aorta, and that is absolutely sphincter tightening scary. I'll tell you, number one, prevent that. And how do you prevent it? On your side as a surgeon, just know what tissue tension looks like. And the best way to get your mind's eye right so that that does not happen is watch your videos. Watch your videos, watch my videos, watch Dr. Cleary's videos. Watch as many videos as you possibly can get your hands on so that you know how much tissue tension a respective surgeon is putting and how much the patient can tolerate. And the only way you're going to get that is by watching more and more videos. So again, back to your question about how do you rescue it? Prevent it, number one. And number two, if you, God forbid, that does occur, be quick to grab control of just the tenets of surgery. Proximal and distal control, make sure you have good exposure. And this can absolutely be handled robotically. Just as long as you can keep your cool and keep control and leadership in the operating room. Okay, next question here. I see you often dissect with the scissor. Okay. Randall Cooper's asking, I see you often dissect with the scissor and hook. Why not use a vessel sealer? Question is this. Let me ask you, in an open case, like an open LAR, and you're trying to skinny down the, mobilize the left colon, for example, do the medial, the lateral, whatever it is, using Bovie or using like a ligature? The thing is with the vessel sealer, I love the vessel sealer to seal vessels. Now, a vessel sealer is great, but it welds the tissue planes together. And honestly, you can burn through the aorta and not even know it because it does a good job sealing. So I like to know that if I'm ever off plane, it will bleed. And I know immediately that I'm in the wrong place. Actually, Dr. John Marks always says this. He says that the only defense an anesthetized patient has against a surgeon is bleeding. So that's the manner in which self-defense of a patient can be shown, is when they start bleeding because you're not in the right plane. So that's why I like using scissors. Okay, anonymous attendee asked, unrelated to this topic, how do you get laparoscopic access? Great question. So what I do is I do a right upper quadrant optical entry technique using a 5mm either air seal port or a 5mm just optical entry port like my Ethicon or whatever, and that works pretty well for me. Dr. Zerhoni pardon me if I messed your last name up, Yasmin, is asking, what's the advantage of the sub-IMV approach? Do you only use it if infra and supra IMA are tough? Oh, great question. And I kind of mentioned this earlier, but the sub-IMV approach, absolutely beautiful. If you're a routine splenic flexure takedown type of person, do that. That's a great way to go. It's relatively avascular. It's easy-ish to see. You can kind of see it. And then it really sets you up to go right directly into the lesser sac to take the splenic flexure down. Many of my partners now do this, and that's all they do. They do sub-IMV, and then they work their way down to an IMA. Just like you mentioned in your question, I am selective with the sub-IMV approach. I go sub-IMA, and if that fails in helping me identify the left ureter, then I go supra-IMA. If that also fails in helping me get into the right plane, then I go sub-IMV and then work my way back down south to connect all the dots just to figure out where the correct plane is and really just stay true to the section. So yes, exactly like you said there. Okay, Nicholas on again is asking, what type of instrument is the easiest using? Looks like it would grab the bowel nicely and atraumatically. Yeah, so that left-handed instrument that you saw me using is a fenestrated bipolar. The fenestrated bipolar, Feni-Bi, depending on how you say it, the fenestrated bipolar is great. It's actually on the spectrum of kind of compression and how aggressive instruments crush tissue. It's on the lower end, not the lowest. There are lower instruments, like the tip-up Grasser is by far the lowest. Next one up, slightly more aggressive, but still very non-aggressive, is the Cartier forceps. Cartier and the fenestrated bipolar are pretty equivalent in terms of grasping and compression strength, and that's why I like it, because it's tough to squeeze down so hard that you destroy something with that fenestrated bipolar. It can be done, but it's not as easy as, say, a needle driver. Needle driver has the most compression, and you can crush anything with that. So be careful with what you're using on the opposite end of the spectrum. Dr. Riyad is asking about, thank you for your compliment, Joseph, asking about splenic flexure tumor. Do you do left colic transection, and what kind of anastomosis? Yeah, so splenic flexure tumors and splenic flexure resections, this is controversial. I love doing just a segmental colectomy on those. I'll do a sub-IMV approach, get above the pancreas, hop in lesser sac, divide the transverse colon roughly just at the left, I'll divide like the left branch of the middle colic, divide the left colic, take a nice chunk of the splenic flexure plus the transverse plus the descending colon out, and usually do either an iso or anti-peristaltic transverse to sigmoid anastomosis. I have a tough time saying that I need to, because of splenic flexure tumor, take the entire left colon, or say take the entire right colon and do an extended right with like an iliosigmoid anastomosis. It's just something I haven't found the data to support either way, and I'm of the mindset if you have a good lymphadenectomy, doing a high ligation, and the vascular supply looks good by way of ICG, then that to me is a good way to do it. That being said, I have Professor Bob Cleary on the phone. Dr. Cleary, can you give us your wisdom on Dr. Riyad's question about splenic flexure tumor resections?
I concur. In fact, there's a lot of recent literature comparing different approaches to splenic flexure neoplasms, and they pretty much conclusively show, including meta-analyses, that a segmental resection is as good as larger resection. So I'm with you on that one.
Great. Thank you, sir. And Bob, good to see you, my man.
Thank you.
All right. Rebecca Brown, great question. Sorry, Rebecca Rowan. Oh, Dr. Rowan, good to talk to you. So thoughts on the new generator. There's the new generator called an E100 generator by Intuitive. And she's asking and wondering if I'm still burning 4 times with it. All right, so true story. I helped develop the E100 generator and the SynchroSeal vessel seal, the new one, the 5mm one. And all that being said, sounds great, but I don't have it. I still don't have it. So even despite all that, I still don't have it in my OR. And so I don't know the answer to that question, but I'll tell you that it doesn't change the compression, doesn't change the sealing quality. It just speeds it up based on some different electrical algorithms and current algorithms. And so that is my understanding, but I haven't had it in my OR yet to actually tell you on a human what it would do. Dr. Clear, do you have that yet? Or do you have any experience with it?
I do not. And I was asked about it. And so I posted it on Vince Obia's Facebook page
Yeah.
to get some responses. And there are many who said it was a game changer. So I guess we'll have to look into it. The only thing that bothers me is that with that new vessel sealer, it doesn't take 7 millimeter vessels, but
Right.
there are some positive aspects to it. And I'm sure there are others out there more knowledgeable than me.
Yeah, the good thing is that that E100 generator works on the just classic vessel seal extend, and it cuts the seal time from like 3 seconds to like 0.9 seconds. So it's ridiculously fast. So it's pretty nice. So thanks, Rebecca, for the question. All right, Stuart Whitney asks, what is your strategy when you're off on your initial incision of the peritoneum over the promontory? Oh, great question. Yeah. Like finding the ureter, getting back in right plane. Yeah. Oh, great question. Like every case this happens, by the way. So you think, I showed you all those little, jiggle the peritoneum here and size right there. I'm probably off, I don't know. I mean, let's call it, I don't know, a third of the time I'm off. Maybe 25%, maybe 50. I don't know. I haven't measured it, but like not insignificantly do I mess that up. And just imagine, if you're off with anything, right? Let's say your incision, you made it here, but you really need to be down here. Just change the dissection just to kind of scoop underneath and lift it. That's all you have to do. You don't have to make a new incision unless you're like a foot off. But if you're within a couple millimeters or a centimeter or so, no, just look to see what happened. Are you above or below? And what do you need to do? And actually, if you give me a second, we can go to the next question, and maybe Dr. Clear, you can answer the next one, and I can pull a video up for Dr. Whitney to demonstrate me salvaging my wreckage from a case. So I'll stop that one, and I'll go back to the next one. So Muhammad is asking 2 questions for diverticulitis cases. Do you take the superior hemorrhoidal and leave the left colic? And your advice for best way for video. Okay, I'll answer that one. So Dr. Cleary, let us know, as I'm looking for this video on getting back into the correct plane. Dr. Cleary, what do you do for diverticulitis cases? Do you take the superior hemorrhoidal and leave the left colic, or do you do high ligation of your IMA? What do you do in those cases?
I have done both, but more often I will take the superior hemorrhoidal just distal to the left colic. You made some good points earlier about routine IMV, splenic flexure mobilizers. Some are routine, some are selective. And this is another one of those points where some argue taking proximal to the left colic even for diverticulitis. Some argue distal, and I don't feel strongly about the argument, but more often than not, I take it distal to the takeoff of the left colic.
Great. All right, this video, not very good, but it'll show the point. Actually, you know what? Let's do this. I'm gonna show this video. Yeah, let's do that one. Okay, I'll play this video again. I have plenty of mess ups, but I think this video that I showed that I borrowed, it's probably actually a pretty good one to show this. So let me show you what I would normally do. All right, right here. Let me pause the video. Oh, crap. Sorry. Let me let the video play. We're gonna go to the burning of the burning of the iliac right there. Okay, right there. All right. It's kind of tough to see in this video, but let's just pretend. I mean, not pretend. This is a scoring of the peritoneum, and if what we've done here is we've gone too deep, right? All you're gonna do is you're gonna stop. You're gonna step back, and I'm talking. You stop the case. You zoom the camera out. Reassess what just happened, and then in this case, the surgeon went too deep, obviously. So what you're gonna do is you're gonna back out and figure out what looks correct. In this case, right here, what the surgeon does is he clearly realizes that is too deep. So what does he do? He just backs up and then is going to readjust the plane to get into the correct embryological location. And that's exactly what I would do in any single operation. He's doing a good job checking to make sure that vessel's okay, but that's exactly the way to do it. But you must be confident enough and humble enough, truthfully, to stop operating for just a second, get up, zoom out the console, zoom out the here. This actually doing a great job here, because look, all this was too deep, and now this surgeon realized he or she was too deep, and now is readjusting the plane to come up here. That is perfect. And again, exactly what I would do, and exactly what any one of us would do in these operations. So the key to this is recognizing it early and knowing by video review what it should look like. Please hear me. Watch your videos and make sure that you're watching other people's videos as well. Oh, Dr. Wheeler, go ahead.
Dr. Solomon, what about you? Proximal or distal to the takeoff of the left colic?
Oh, I try to do a high ligation every case. I try to do, and honestly, it's not because that specific patient needs it, but I want to make sure that when I get to the important cases, cancer cases, those cases I really need to get high ligated on, then I know I've practiced it hundreds of times. And that way, like a true legit high ligation IMA or IMV is not reserved to my 20, 30 rectal cancers I do a year type thing.
Selective splenic flexure mobilizer or routine?
Selective. So I used to be a routine kind of guy, and then I realized that when you do a high ligation on the IMA and a high ligation on the IMV, that gives you the majority of the length that you need for a lot of these cases. So you don't need necessarily to do a splenic flexure takedown. How about you, sir?
Yeah, I'm selective splenic flexure mobilizer.
Okay, great. So Mohammed, just to circle back on your second part of your question, the best way of video editing and reviewing your own videos, if you can do something, if your operating room has a method by which your videos can be recorded, please do that. We have something called CSATs where our videos get uploaded to a cloud and they get reviewed by a third-party review website. If you don't have that, and you have like a Striker tower just to record your videos, do that. If you don't have that, shoot me an email, because I can show you kind of a ghetto way to get a video capture card from Amazon, plug it into the back of the robot with an SD card put in. It just pulls the video directly off, and you have it on an SD card for your consumption later on. And
Are you willing to share what software you use for editing?
yeah, so I used to use iMovie for everything until maybe like a year or two ago. I started doing a lot more like video type lecturing and annotation and whatever. And so for those, I use something called Camtasia for the voiceovers. And then like when it's like actual video production, I'm cutting, splicing, and all that really are kind of a higher end video production. I use something called Adobe Premiere. But Camtasia is a really good app for clipping, and it's super simple to use. Okay, Dr. Lee seems to use ICG and ureteral stents. Yeah, good question. So this case here that I showed, this lady had she had ureteral encasement by tumor, and so for that reason we put a stent up and injected ICG. I don't normally do that, but if I ever do, I inject 3 cc's of ICG up the stent, and that's kind of how it works. Olga Garcia, good to see you, Olga. When you do you then use vessel sealer or suture ligation when you grasp the IMA stump? We've used an endoloop on calcified vessel. Yes to all that. Yeah, I mean, a lot of times I'll just use a vessel sealer. If it's calcified, instead of sealing it 4 times, I'll seal it 14 times. I just keep going and do what has to be done. But in a second, I'll ligate it with an endoloop. That's usually my go-to is vessel sealed and endoloop. I don't really do stapling. I really don't do suturing. But we'll do it in a second if that's what it took. Dr. Cleary, what do you do for those more those IMA stump leads or anything like that?
For the bleeds, your
Yeah.
point about being calm was perfect. And if you can get something in your left hand, put a endoloop on it, or the laparoscopic device that you can put a circle around it. I don't do that much, but yeah, it's staying calm and getting control with it, and then saying, okay, now how are we going to address this is the best way to do it.
Yeah. Dan Popowich, you guys may know him, is a colorectal surgeon out of Long Island. Dan posted this ridiculous video. I was on one of the Facebook groups where his assistant avulses the IMA off the aorta. There's a big old hole in the aorta. It looks like just a geyser. That dude, I mean, he got control of it. It was the slickest thing I've ever seen. He oversewed it. I think he with pledgets. It was ridiculous. I mean, I had heartburn looking at it, but he did it and he remained calm. It was absolutely incredible. So, yeah, we have to find that video. I think that's Lily, I believe, Purvis, asking, does a patient's comorbidity influence your decision on which instruments to use for ligation dividing vessels? Not really. I mean, I will seal with the vessel sealer obsessively. And again, if it looks like it just doesn't seal well, then I will do a ligation with an endo loop. And I think Dr. Cleary, similar to you, Dr. Cleary, or do you like staple or anything like that?
Yeah, no, I agree. I use the clips in addition to the vessel sealer, so I overdo it.
Got it. Yeah, nice. No, it's good. All right. So, anonymous attendee is asking, do you use a robotic zero camera for Optiview? No, I don't. Actually, I still use a 5 degree, 5 millimeter 0 degree scope to get in the abdomen. And the reason is because I get in through the right upper quadrant using an optical entry technique. And so I don't open a robotic 0 degree camera for that specific entry point. That being said, I do know that I think Intuitive was coming out with a 5 degree 0 scope just for first entry. We don't have it, but I know that it's available. But I will tell you this though. I use a 30 down for everything, every single case. But once I get below the sacral promontory, then I switch over to a 0. Actually, I go below the sacral promontory, I go to 0. I think everyone does it different. I think, Dr. Clear, you actually go 0 and then switch to a 30 below the promontory, right?
Correct. Yeah, I use a 0 for a lot of it, but I'm starting to use 30 more often.
Yeah.
I let the fellows talk and residents talk me into it.
Yeah. So next question here about synchroseal instead of using vessel sealer, and forced bipolar instead of fenestrated bipolar. So forced bipolar can grasp mildly or grasp aggressively. So it works. It's fine. It's just added cost, and I'm happy with fenestrated bipolar, and it works just fine. But yes, forced bipolar on the lowest setting is very safe to use on bowel. Just try not to make it a habit. And then synchroseal instead of vessel sealer, the FDA has cleared it for 5 millimeter vessel utilization, not 7. It's a small but significant number in my opinion. And so I choose to stick with the vessel sealer more I don't have the synchroseal, even though I helped develop it. But I don't think I would I'd switch to synchroseal and for just because of that reason. I don't know, Dr. Clear, do you have synchroseal, you said?
We do not.
Okay. Raphael Byrne is asking, do you leave the patient Trendelenburg as you continue to medial lateral dissection, cephala towards a lesser sac and begin the flexor takedown? Short answer, yes. Very rarely, and I mean very rarely, do I have to take them out of Trendelenburg and do like a reverse Trendelenburg to finish the flexor takedown. The Trendelenburg position trips us up because we feel like all the bowel is going to be at the splenic flexure. And that's true, but if you have enough right-sided tilt and then you take your time at the beginning of the case to laparoscopically sweep all that small bowel out of your face, you will be fine. And that will actually, that'll be swept out no problem. And you can actually take the flexure down in a steep Trendelenburg position. So just something to keep in mind. And any advice for splenic flexure takedown logistics if you don't have table motion? Yeah, fun fact. I had I did my first 200 cases with no table motion, and then table motion came out. I've had table motion for the past 500 cases, and I probably use it maybe once or twice a year, like actual table motion in the case. I almost never use it. That's because I got so good at, and I mean this in a humble way, but I got so good at just sitting the patient up and never moving them during the case that it's really not that necessary. But clearly, we use it. on occasion. Dr. Cleary, any comments on that?
No, I concur.
Okay, great. And I don't want to go too much over, but some really good questions coming in. Yeah, great question, Nick. Do you have situations where the small bowel just would not get out of view while you're trying to start the infra IMA approach, and how do you deal with that situation? Yeah, I mean, you got to ask you got to ask yourself why. Do you have enough right side down? Do you have enough Trendelenburg? And I'll tell you, even in larger patients, if you put them in enough Trendelenburg, we're going to put them in enough right side down, and then take your time at the beginning of the case to laparoscopically position the bowel into the right upper quadrant. There's been very few cases in which I don't get get the small bowel out of the pelvis. It happens, no doubt. But usually the other questions I ask myself is, do they happen because there are adhesions in the pelvis? What's going on and why isn't it? And usually once you answer all those questions, almost always the small bowel will get out of your face. Sometimes they're just too big and the bowel is too distended to do it. And then you just gotta, unfortunately, I hate it. It sucks. You just kind of have to get through in those cases. But usually it's a positioning issue. Usually you haven't taken enough time to sweep the small bowel, or there's some sort of adhesion holding you up. All right, Dr. Cleary, for you, sir. Do you do your own cystoscopy and ICG injection into the ureters, or do you let urology do that? And if so, which cases?
Well, my partners do them routinely, so I don't have to call urology. I'm a selective ureteral stent user, and so if I do use one, and it's probably 3 to 5 times a year, then I'll ask them to do it for me at the beginning of the case. Are you a selective stenter or a routine stenter?
Yeah, so I think your two partners trained at our program, and then so my half of my group at the time could get stents. If you sneezed, you got a stent. Yeah, everyone got stents, and then it was easy to get them. But everyone in the audience today, you may go to a place like me that getting stents is like asking a favor. You gotta have a buddy that's gonna put the stent in for you, and a lot because it doesn't pay very well. So I had to get really good at finding the ureter on my own. And so, no, or yes, to your question, Dr. Clear, I am a selective stent placer, just because they're not that easy to get when you're out in the real world. Many of you in the audience today may be at an academic institution in which you have fellows and residents and people just tripping over you to put stents in. But when you're out in the real world into a private hospital or a hybrid community program, whatever, stents is not that lucrative of an operation or procedure, so it's difficult to get them placed. And the last question here is unrelated to the current topic, but for difficult diverticulitis cases. I'll give this one to you, Dr. Cleary. Do you ever use lighted ureteral stents? And so when you do place them, what type stents are they placing?
You know, they inject the ICG, and sometimes they leave the stent in, or yeah, and sometimes they take the stent out after injecting the ICG, because that ICG lasts for the duration of the case most of the time. One of my partners does use a lighted ureteral stent, but I'll be honest with you, I'm not the guy to ask about compare and contrast because I just don't use them that much.
Yeah, so I can, I will tell you that the Striker makes this ridiculously amazing bright. It's like a bright yellow or bright white, blinking runway. It looks like you're like landing a plane. And they're fiber optic lighted stents that go up, and so you don't have to inject ICG. It's just a big bright light. It looks like a halogen light bulb in the pelvis, and it's fiber optic, so it doesn't burn the ureter or anything like that. So when I do those, that's what I do. All right, those are all the questions in the Q&A. Anything else, guys, girls, anyone? Don't be shy.
Mark, one more thing I have to ask you. You taught yourself the robot, as I recall, as I did. How would you advise young surgeons going out into practice who don't have someone they can go through the learning curve with when it comes to IMA and IMV, or just robotic approach in general?
Yeah, no, it's a great question. I think that I think the most important thing is if you this should not be the issue with those in the audience today, because many of us And nowadays, it's extremely common to have robotics training in fellowship. But if you do come from a program, you get 1, 2 cases, you're incredibly uncomfortable. Don't start your practice doing robotics. I've said it. Make sure you know how to operate first. Make sure you can get yourself out of trouble laparoscopically. Make sure that you're safe and you have established yourself as a competent and safe surgeon first. Now, if you've had dozens and dozens and 30, 40, 50, 60 robotic cases, that's different. But if you're on case 3 and you graduate, you're kind of starting from fresh. And so in those instances, I have a video on my YouTube channel talking about navigating the robotics colorectal learning curve. And that really talks about knowing yourself, what your goals are, set realistic goals throughout the case. And I think in this case, if you're only comfortable taking, for example, the IMA and IMV laparoscopically, and you're still learning to do robotic surgery, start by taking that IMA and IMV laparoscopically, and then dock to do, for example, the lateral mobilization, a little bit of the TME, and then open, for example, or finish it lap. Once you're comfortable doing that section of the operation robotically, then begin to advance yourself in a stepwise iterative process. And then you must find yourself a mentor, whether it's Dr. Cleary, Dr. Bastaris, Dr. Rashidi, whoever it is, myself, any one of us, your faculty from fellowship. We live and breathe, and this is why we went into medical education, surgical education, is to be a resource for the next generation of surgeons. So please don't be shy to lean on us to bounce these videos off. And I'll say it one more time. One of the most important things that you can do is watch your videos and watch someone else's videos. Watch how it's done well, watch how it's done poorly. Watch videos, because you will learn from the mistakes of yourself and others, and learn from the good things that others did and what you did, and you'll be able to amplify that in the very next operation that you do.
Great. That was excellent, Mark. You did a great job teaching us in language that everyone can understand. Excellent job.
I appreciate it. Thank you so much, Dr. Cleary, for the privilege and the honor, and thanks to everyone in the audience for attending, and thanks to our partners at Intuitive for the resources and the capability to see this. And we're really, really, really looking forward to seeing every single one of you guys at the live courses that are being scheduled. So make sure that that you guys are all signed up and your case logs are updated. And the next one, Dr. Cleary, is when? Do we know?
In person. Oh, the next
webinar.
Webinar. I think it's April 18th. Splenic flexure mobilization. And the next in person is in May, and I can't wait for that.
Yeah, likewise.
It'll be good to see everybody.
Yeah, right. All right. You guys be good. Have a wonderful, wonderful day. Have a wonderful Sunday, and you guys be and keep in touch. Take care.
Bye. Thanks again, brother. Have a good evening.
Thanks, Bob. Thanks, Bob. See you.